I want to begin my talk with this invocation in Sanskrit. I must confess that I'm no Sanskrit scholar, so pardon my pronunciation. This is an universal prayer. Om Sahanavavatu Sahanau Bhunaktu Sahaviryam Karavavahehi Tejasvinavadhitamastu Ma Vidvishavahehi. Om Shanti, Shanti, Shanti. Let us all learn together and utilize this knowledge together. Let us achieve victory together. Let the sun shine on us and bless us. Let there be no conflict amongst us. Let there be peace in our hearts. As I stand before you today, I am filled with one overriding sentiment, namely that of gratitude. I am grateful to the membership of the society, that is all of you, for conferring upon me the rare honor and privilege of serving the society as its president. Shariram suropam tathava kalatram yashascharu chitram dhanam meru tulyam manaschanna lagnam gurorangri padme tathakim 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 tathakim. Even if you have a handsome body, a beautiful wife, great fame and money as high as a mountain, if your mind does not bow at the teacher's lotus feet, what is the use, what is the use, and what is the use? This is the first stanza of an octet named Guru Ashtakam by Adi Shankara, one of the great saint philosophers of Hinduism and proponent of the Advaita Vedanta stream of thought. I bow my head to all my teachers, some of whom are shown here, with what I tried to learn from each. I consider it a privilege to have studied and to work at the 114-year-old Christian Medical College, Vellore. It provides a nurturing environment which promotes ethical health care with the interests of the patient being uppermost, encapsulated in its motto, not to be ministered unto, but to minister. I have spent nearly 40 years of my life at my alma mater. I have been profoundly influenced by the thoughts and deeds of the founder of my department, Professor Jacob Chandy. He was a true visionary. Professor Chandy trained with Dr. Wilder Penfield at Montreal and returned to India to start the first department of neurosurgery in India and this part of Asia in 1949. I would like to thank all my colleagues, especially in my unit, who have covered for me during my frequent absences over the past 1 or 2 years. I acknowledge the efforts of my late parents and the sacrifices of my mother in particular. She ensured that I received uninterrupted schooling in spite of the frequent transfers that my family had to endure due to my father's job as an army doctor. Last but not in the least, a debt of gratitude to my wife, Rupa, who's here with me, and my son, Aditya, who have had to put up with my late hours at work and crazy travel schedule and some of my personality traits that I will be sharing with you shortly. In common law, brain surgery and rocket science are considered to be the acme of human intellectual achievement, reserved for the smartest of the smart. It remains a matter of debate as to which requires more intelligence. While that may make us neurosurgeons smug, we have to contend with this perception of our personality. We are considered to be rude, unfriendly, bossy, arrogant, and in love with ourselves, not to talk of our hubris. I must confess that I share some of the personality traits that have been shown here in this cartoon. I will let you decide which of those traits are common with the cartoon character. My colleagues may argue that in fact I share all the traits with this character shown in the cartoon. But I dare say I am in good company. Fortunately, we do have this desirable stereotype of a neurosurgeon, although we would be mortified if we lost our car keys in a patient's brain. But should brilliance, good personality, or hubris provide our identity? I want to put it to you that in fact the defining trait of a neurosurgeon should be excellence, because that is our legacy. It is not a mere coincidence that gatherings of neurosurgeons such as this celebrate excellence. The Oxford English Dictionary defines excellence as the quality of being outstanding or extremely good. But excellence is a much bandied about word, and I'm sure that each one of us our take on it. I will spend the rest of my talk in giving my perspective on it. First off, let me remind you that excellence is a quality that is different from brilliance or being successful. As this now disgraced American football coach says, excellence is largely within a person's control. And if you try to be excellent, the chances are that you will be successful. But it does not necessarily work the other way around. Let us go beyond the dictionary meaning of excellence, quality of being extremely good or outstanding, to delve into what excellence really represents. I have taken the help of these eminent men to understand the meaning of excellence. The common thread that runs through their definitions of excellence are qualities of earnestness, dedication, sincerity, hard work, and persistence. And as Lincoln said, excellence is not a destination, it is a journey. It's also clear from these quotes that excellence is not something we are born with. Everyone can aspire to excellence, and no one is excluded. We must also recognize that human excellence is not measured on an absolute scale, but is relative to the achievements of other humans. Who created this fortunate legacy for us? Although several neurosurgical giants exemplify excellence, several of those giants are from our country. To my mind, Harvey Cushing epitomizes it. Arguably, therefore, it is Harvey Cushing who deserves most of the credit for this legacy. He was portrayed by the press of his time as the prototypical brain surgeon, which accounts for the enduring layperson's image of a neurosurgeon. For the purposes of my talk today, I have used Cushing as the exemplar of excellence. Cushing was much more than an accomplished neurosurgeon. His legacy lives on with us in the form of the several eponymous conditions that span many medical specialties. Some of the lesser known achievements of Cushing are listed on the right. One of the more remarkable achievements for a busy neurosurgeon was the Pulitzer Prize for his 2-volume biography of his mentor, Sir William Osler, published in 1925. I have taken the liberty of quoting extensively from this unbiased and well-researched biography of Harvey Cushing by Michael Bliss in my talk today. This book, by the way, was gifted to me by Dr. Anil Nanda of Shreveport, Louisiana, and I'm grateful to him for that. We will come back to Cushing on and off throughout my talk, but let us now get back to analyzing what constitutes excellence. We have defined excellence, but how do we measure excellence in our field of work? All of us sit on the famous three-legged stool. So I will try to discuss the issues of metrics of excellence in the domains of clinical care and research. Limitations of time do not permit me to discuss excellence in teaching. Let us begin by discussing excellence in our clinical work. Excellence in clinical neurosurgery in an era where visual imagery reigns supreme frequently involves display of images such as these, which show complete removal of difficult tumors with presumably an intact patient. These are images from some of my patients. The upper panel on the left shows the preoperative and follow-up images of a woman with a large intrinsic brainstem schwannoma with intraoperative facial EMGs showing preserved function after removal of this tumor. The lower panel on the left, a giant vestibular schwannoma, and the panel on the right shows a large dumbbell trigeminal schwannoma which has been excised completely and has not recurred over 7 years. Similar preoperative and follow-up images, but the setting is that of central corpectomy for cervical spondylotic myelopathy. The MR images show good decompression of the cord. The X-rays show good bony fusion following uninstrumented 2 and 3 level corpectomy. But images such as these are anecdotal examples of surgical excellence and do not represent hard data. As was famously said, in God we trust, all others, that is us, bring data. So we need to present data to convince our peers of our surgical results. That is what Cushing did. These figures from Cushing's series of brain tumors show his remarkable success in an era when other neurosurgeons reported dismal figures. While we may consider his mortality rates to be too high, we must not lose perspective. Remember, this was nearly 100 years ago, and he achieved this level of success with surgical tools and other paraphernalia far less sophisticated than available to us. Around the same time, Ernest Sachs, Sr., had reported a mortality of 35.5% in 85 cases, Olive Krona from Sweden, 30%, and Eiselberg from Germany, 46% in 333 cases. So Cushing's results were excellent for that era. This underscores the point that excellence is relative and not absolute. For an example from the modern era, I have chosen this article which provides the benchmark for the surgical management of vestibular schwannomas. It reports the results from the master surgeon Majid Sami. The focus of the results reproduced here is on the high rates of total excision, preservation of the facial nerve and the cochlear nerve, and the low morbidity and mortality. By all measures, this is true excellence. But do these results convey the full picture? What happened in the long term? And how did these patients perceive their function? What was their function? What was their quality of life? These features or these outcomes do not come out in this article. Cushing realized that once the hurdle of reducing mortality from brain surgery was crossed, the focus had to shift to the surviving patient's functioning. He mentions in his monograph on brain tumors that more important than mere enumeration of patients alive and dead after the surgery was their long-term outcome with respect to their daily activities and ability to work. Hence, towards the end of his career, he let 3 of his fellows investigate precisely that. Van Wagenen looked at the long-term outcome in patients with gliomas, 8-year follow-up. Hugh Keynes did the same, for all brain tumors, 10-year follow-up. And Henderson focused on pituitary adenomas. A long-term follow-up of our patients is also necessary to understand the effects of a particular therapeutic protocol, surgical or medical. The Kaplan-Meier survival curve on the left, I'm sorry it hasn't reproduced so well, shows the long-term outcome in our patients with tuberculous meningitis and hydrocephalus undergoing shunt surgery who were followed up for up to 13 years. Mortality continued to occur in grade 2 and grade 3 patients for several years, finally plateauing at around 10 years after discharge. The Kaplan-Meier survival curve on the right is in patients with a solitary cysticercus granuloma of the brain, followed up from 2 to 10 years after withdrawal of anti-epileptic drugs, which shows that seizure recurrence is usually seen in the first few years after stopping the drug, plateauing at around 3 years. It also shows that calcific residue, that is this curve, is a risk factor for recurrence of seizures in these patients. But longevity alone does not constitute good surgical outcome. Assessing patients' functioning status, such as ambulation or activities of daily living, brings us closer to understanding the true surgical outcome in our patients. We found that up to 75% of our patients in poor neuric grades, these are patients who cannot ambulate independently, they require the help of either a stick or walker, and those in grade 5 are actually bedbound, had improvement of 1 or more neuric grades, and more importantly, 25% of them improved to neuric grade 0, that is asymptomatic, or grade 1. This justifies decompressive surgery in this group of functionally disabled patients. For a more comprehensive assessment of the impact of surgery, quality of life studies are necessary. In this prospective study on 70 patients undergoing central corpectomy for cervical spondylotic myelopathy, we used 2 generic health-related quality of life instruments, namely the short form 36 and the WHO quality of life BREF. We concluded that both instruments were useful in demonstrating the beneficial effects of surgery on the patient's quality of life. You can see the p-values here, showing statistically significant improvement following surgery between the pre and the post-op scores. In another prospective study on the quality of life in 100 patients with large and giant vestibular schwannoma, which was published online, it has still not come out in print in Journal of Neurosurgery this month, we found that quality of life improves in nearly 85% of patients after surgery. This is in contrast to what is reported for small tumors, where it has been shown that the quality of life actually worsens following surgery. Nearly 70 to 80% of our patients achieved what is termed as minimal clinically important difference, or MCID, in their domain scores. MCID improvement rates are important as they reflect a true change in the patient's quality of life and not just a statistical change. So a comprehensive assessment of the patient and the pathology are needed to determine surgical outcome. But do only these patient outcome measures count towards the judging of the excellence of a surgeon? Of course not. How does one quantify ethical care, empathy, compassion, and courteous behavior in dealing with one's patients as a measure of excellence in clinical care? Numbers do tell a tale, but not the full story. We move on to the second domain of our work, namely research. In recent years, the application of bibliometrics or scientometrics has made the metrics in the domain of research more objective and quantitative. The number of citations of an individual article is an important measure of the utility of an article. Any article which has more than 400 citations is labeled a citation classic. But number of citations does not measure the consistency of a researcher. So other indices shown here, the H index, the I-10 index, and several other indices have been recently introduced. H index was introduced by Hoey Hirsch in 2005. It is one of the most popular indices of the indices that have been recently introduced. It's one of the most popular to measure the impact of a researcher in the domain of research. It reflects the productivity and impact of a researcher or an organization using a single number. It is defined as the number of papers of a scientist which have the same number of citations or more as shown in this graph. For example, H index of 20 indicates that at least 20 papers have 20 citations or more. This article found that H index correlated well with the seniority of the surgeon and his or her academic rank. On an average, assistant professors had a H index of around 5, associate professors around 10, and professors over 18. This was an article from the United States and looked at faculty in 10 top-ranked neurosurgical departments in the US. Anyone can check out their individual H index by signing into Google Scholar, Scopus, or ISI Web of Knowledge. Although not perfect, it is considered a better indicator of research output than the traditional measures. Several scientific academies use the applicant's H index as a screening measure. H index of 45 required for entry into the US National Academy of Sciences is extremely high. I-10 is another index which provides a number to measure the effectiveness of one's research. It gives the number of articles that have received 10 or more citations. Other indices such as the HC index, G index, and M quotient overcome some of the weaknesses of the H and I-10 indices, but these have yet to gain popularity because they are more complicated to calculate. Like all measures, no one index is perfect. So probably excellence in research, like in patient care, should be evaluated using different tools and indices, and even then, qualities such as mentorship and integrity of a researcher cannot be captured by any number. We have recognized what is excellence. We have some measures of excellence for our work, but how do we achieve it? I think I come to the most important part of my talk. Two philosophers and an American botanist give us some guidance. Most importantly, there has to be the will and the desire to achieve excellence. Repetition and hard work will then take you to your goal. So basically, it's something that has to come from within and cannot be forced upon from outside. So we go back to Cushing on how to achieve. Cushing personified attention to detail. His articles about brain surgery give an insight into his attitude towards neurosurgery. No detail was too small for him. What we would consider as trifles were very important to him. He deservedly earned the reputation of being a perfectionist. I guess crotchety frequently goes with attempts at perfection. Presented here are some more of Cushing's artwork. The third trait was his uncanny ability to use opportunities that came his way. One cannot imagine that a battlefront could be an appropriate place for careful documentation and record keeping, but that is what Cushing did. He used his time serving in World War I to evolve protocols to treat patients with penetrating head injuries and improve their outcomes. His meticulously documented experiences led to the publication of a monograph on the treatment of these patients, which remained the standard reference for several decades. There is a lesson in this for all of us on how to spot opportunities even in the most unlikely circumstances. I am sure that most of us will attribute Cushing's success to some innate skills. It is a common perception that one needs to be immensely talented or born with some God-given gifts to be excellent in any field of human endeavor. But both these authors, Malcolm Gladwell and Jeff Colvin, amongst many others, have debunked the myth that innate talent plays a major role in achieving excellence. And this has come about in the last 2 decades or so. Gladwell showed that most outliers, that is, those whom we consider to have achieved excellence, had to work very hard and practice for at least 10,000 hours before they reach the summit of excellence. Colvin also supports this theory and has worked out that it takes at least 10 years of what is termed as deliberate practice to be a master in any field. Look at the coaching model here. Just practicing skills in this zone, that is the comfort zone, that is the zone in which we practice skills that we are already good at, is actually termed mindless practice because it doesn't take you anywhere. This will not enhance our skills. We need to move into this zone, named the learning zone. But be careful not to jump into what is termed as the panic zone. That is skills, at least at a given point in time, which are obviously beyond our capabilities, but because that will put us off completely from improving our skills. So we need to move from comfort zone to learning zone. As you can see from the panel here, we can achieve this through what is termed as deliberate practice, not mindless practice, mind you. But deliberate practice needs a coach or mentor, is more mentally demanding than physically demanding, and very importantly, is not fun. One of the other major components of deliberate practice is feedback. Feedback from our clients or patients in our case, peers and mentors. Gladwell also documents how successful people leveraged available opportunity, just like Cushing did, while those less successful with the same capabilities ignored their opportunities. So as deliberate practice is not fun, what comforts high achievers during their 10,000 hours or 10 years of practice? An inner desire to excel, passion, and the expectation of fulfillment are factors that mitigate the misery associated with the tedium of deliberate practice needed to achieve excellence. Thus, it appears that practice, focus, maximal utilization of opportunities, and feedbacks are the 4 mantras that any one of us can adopt to achieve excellence. If one were to ask whether these tenets can be applied to surgical excellence, it is evident that they would work well for us. In particular, feedback through clinical audits and outcomes research improve our competence. Feedback gives us insight into where and why we went wrong, and this in turn makes us seek and identify skills required to overcome those deficiencies. These skills are then acquired through deliberate practice. We are all probably convinced that practice makes perfect in the surgical field, but only recently has there been hard data to substantiate this common belief. The 2 studies shown in this slide report on the effect of surgical volume on surgical complications. Both these studies showed that higher surgeon volume and specialization were associated with better outcomes. So repetition and focus improve patient outcomes, and achieve excellence in a particular field of surgery. This slide showed that if you operated on at least 6 brain tumors or more, then your outcomes in hospital mortality and complications would be better than those who did less. Here is our experience with the learning curve. In a series of 410 patients undergoing uninstrumented corpectomy for spondylotic myelopathy, we had the maximal graft extrusions in the first 100 patients. In fact, all 6 were in the first 50 patients. Subsequently, graft extrusion was almost completely eliminated, which showed the effect of practice improving outcomes. Simulation is another way to develop surgical skill through deliberate practice. Although cadavers and generic models such as those used in the NSICON simulation course are a good way to start acquiring surgical skills, they do not expose the surgeon to the anatomy of a given patient. With the surgical theater shown here, one can practice a surgical procedure on the patient's own image and may in future be the standard of simulation. Preventing errors is essential to achieving good surgical results. The efficacy of the surgical safety checklist in reducing surgical errors and improving mortality and morbidity in surgical patients is well documented in this landmark article. Atul Gawande, the senior author of the article, he was quoted yesterday by Dr. Selden, has published this excellent book on how checklists reduce errors in different walks of life. Anesthetists were amongst the first in the medical field to adopt checklists, and now we surgeons have realized their utility. I am a strong proponent of checklists in surgery and clinical care. Well-reasoned protocols are another great way to reduce errors and ensure uniformity of care across different levels of expertise. We have a protocol book for our residents that was started about 10 years ago. But it is a living document which is constantly evolving, as you can see from the version date here. Shown here is a protocol for postoperative steroid use in patients undergoing surgery for pituitary adenomas. While most of us may not be able to meticulously record minor errors as suggested in this article from Mark Bernstein's group, major errors should be recorded in a prospective manner in audit statements similar to the ones used in our hospital. Regular monthly audit meetings should have the benefit of peer interaction or feedback. These graphs from our data tracking surgical site infections and mortality over several years show the trend and capture any upswing which should prompt corrective actions. All these activities provide feedback, an essential component of deliberate practice. I would like to thank Dr. Ranjit Murthy, my colleague, for these graphs. Audit reports can result in a scientific publication that can benefit others. The results of a prospective infection audit maintained by us over 9 years were published in this article. Using what is now considered almost an extinct antibiotic, that is chloramphenicol, as the only prophylactic antibiotic for craniotomies, we were able to maintain a relatively low rate of postoperative meningitis of 0.8%. And more importantly, we kept the multi-drug resistant organisms, or MDRs, at bay with only 0.1% of meningitis caused by these organisms. I would like to use the title of this autobiography by Dr. Wilder Penfield to emphasize the point that in clinical work, excellence cannot be achieved by an individual, but belongs to a team. I will now move on to how to approach clinical research and our experience in this domain of work. Although it is commonly perceived that research belongs in the ivory towers of academia, clinical research need not be too far removed from our daily clinical tasks. One of the attractive features of clinical research as opposed to bench research is the immediacy of the applicability of the results. I will discuss 3 such studies of ours, 2 prospective and 1 retrospective, which has impacted our clinical practice. Hyponatremia with natriuresis is a common clinical problem in neurosurgical patients, which is caused by either SIADH or cerebral salt wasting. Determining which is the cause is important, because in SIADH you would restrict fluids, whereas in cerebral salt wasting you would administer fluids. Till these prospective studies were performed, we used to treat most of our patients with hyponatremia with fluid restriction in the belief that SIADH was the cause. Our studies revealed that in most neurosurgical patients, it is cerebral salt wasting that is the cause and not SIADH. In the second study, we found that a central venous pressure protocol could be used to guide therapy, and for the last several years, we have followed the protocol outlined in this second study. In this prospective study, we investigated the optimal duration of antituberculous therapy in patients with brain tuberculomas. There is no consensus on the duration of therapy, as can be seen from this table here. We found that even at the end of 18 months, up to 70% of patients had a residual lesion. You can see from these figures that in the first patient, there's a small residue at the end of 18 months. Second patient, the lesion has resolved with a calcific residue, but at 24 months. But in the last patient, even at 24 months, not only has the lesion not resolved, but has increased in size. So we suggest that ATT should be given till the granuloma resolves, that is with no enhancement, and there is no edema. Finally, this retrospective study on the prognostic value of the histological grade of a brainstem astrocytoma in children and adults. This study showed that in children, there is no prognostic significance of the grade of the astrocytoma of a brainstem astrocytoma, but in adults, there is a distinct difference in the survival of low-grade tumors versus the high-grade tumors. Following this article, we have changed our approach to children with brainstem masses and do not perform stereotactic biopsy in children with diffuse pontine non-enhancing masses with the typical clinical features of a pontine glioma. I want to suggest that clinical research, especially prospective studies involving surgical outcomes, also improve patient outcomes, because feedback of any kind is associated with better care, and outcomes research is all about getting feedback of our work. Although major scientific discoveries are attributed frequently to serendipity, you must remember that it cannot occur in a vacuum. Excellence in clinical research in future will come less from single institution or single investigator studies and more from large collaborative trials such as this one for traumatic brain injury. Bob referred to registries, and this is one such registry. And I agree with him that I think relevant guidelines about how to manage patients will come from large registries such as this. I want to cite this oration delivered by William Stewart, the Surgeon General of the United States in 1967, which reminds us that excellence associated with our specialties comes at a price, the price of responsibility. Most important of these responsibility is the fourth one, that is to society at large. Most of us in India have received medical education and neurosurgical training at a fraction of what it costs elsewhere in the world. We owe it to the people of India to provide neurosurgical care of the highest standard at a reasonable cost. And I was really excited to hear the talk in the morning by Dr. Prajapati, and I hope that that inspires more people to do what he is doing. As I come to the end of my talk, some advice to the younger members in the audience and the residents. I leave with you the acronym OPP, the first 3 letters of the word opportunity. They stand for opportunity, practice, precision, and an additional P for passion. I believe that the first 3 will put you on the path to excellence in your profession, but without passion, your achievements will not be fulfilling. And expectation of fulfillment, as I said before, is essential to overcome the hardships of the journey of excellence. Remember to adopt the KISS principle in your surgery and not the KICK principle. Finally, trust Harvey Cushing to leave us some sage advice and observations. Ponder on the quotation about a surgeon with no hands and realize that the actual operative part plays the least important part in good patient outcomes. If you remember, I pointed out that deliberate practice is more of a mental effort than physical, so is surgery more of a mental than physical exercise. Don't aim to be a spectacular surgeon or a spellbinder, as Cushing termed it. Painstaking and boring surgery is also good surgery. And have a mentor. Ladies and gentlemen, to counter all the bad press we as doctors and neurosurgeons are receiving, we should secure our legacy and ensure that our specialty and its practitioners continue to be beacons of excellence. I would like to once again express my gratitude to all of you who have attended my talk and listened to it patiently, and for giving me the opportunity to serve as the president of this prestigious society. Thank you.